Good afternoon, everyone.
Good afternoon.
Hi there. It's nice to see you all here in person. And for those of you joining us online, we're happy to have you join us as well for our second session in the Department of Psychiatry from my experience. We're happy today to, actually, before I get to that, yes, you'll see our disclosure slide. Someone said something to me after the last week's session was they plan to start. So we'll just give disclosure sign right there for you. And another little piece of housekeeping, it's Friday. Our registration will be opening for the August series. So feel free to, I know you have the QR code, and most of these QR codes, thank you, near our website, not to our website, but on the flyer, all the information is there so that you may start registering for our August sessions. Today, we have the honor of having Megan Lytle, Dr. Megan Lytle with us, and she is the clinical director of DPS, which stands for Gender Patient Support. And we're excited to have her here. She's also one of our leaders on our DICE board. So we are doubly fortunate today to honor her knowledge and expertise shared with us today. So join me in giving her a round of applause. Hello, everybody. I haven't done polls and a presentation yet, so if you have a moment, please kind of choose which way you'd like to join the poll. I think it would be super helpful, so I just wanted to, it'll show up too on the pages where the polls will be happening. So I don't know everything, and I don't expect that of you either. Language is constantly changing, and I think a lot of times conversations aren't had because people are too afraid to use the language that they have to ask those questions. So please jump in, feel free to ask questions and use the language that you have, and we'll figure it out together. So a little bit about me. I'm a collager. So collage is children of gays and lesbians everywhere. So I am the daughter of a gay man who was absolutely delightful. I was at the Pride picnic on Sunday. And my work was really just motivated by ridiculous things people said to me about my dad. So my research and clinical work was really inspired when somebody had the nerve to come up to me and be like, I think your dad's going to hell. And I was like, I thought we were friends, but I guess not. Because my dad is super religious and probably the most delightful person. He will carry groceries to your car and take care of you all day, every day. But just looking at that made me kind of pay attention. The fact that we still pathologize individuals, that we were pathologizing gay, lesbian, bisexual, pansexual individuals, the fact that we still pathologize trans and gender diverse individuals really impacted my work because it makes no sense anymore pathologizing an identity. And then I recognize legalized discrimination, and it's still there, and it's getting worse for trans and gender diverse individuals. All you have to do is flip on the news, and we're literally erasing their identities state by state. So my work has always been dedicated to LGBTQ plus health equity. But for those of you know the delightful Eric King, my mentor, he has a lovely way of motivating you. And he would always challenge me to think about, like, why are you lumping people together? Why are we not looking at individuals? Because the experiences are different. The experiences of a gay man, a trans woman, a bisexual individual, these are all different experiences. And if we just lump people together, we're losing their essence. And so between my work with Eric and some focus groups that I did, I really recognized the lack of gender affirming healthcare in Rochester, that we don't have a lot of people doing letters of medical necessity, and it really just influenced the trajectory of my work. So I want to talk a little bit about blind spots. We literally receive millions of pieces of information every second. I am looking in this room. You're all wearing different colors. I can hear movement. You're supposed to be eating and drinking. It's a ground bag. But we hear all of that. Like, all of this information is impacting us. We can handle 40 to 50 pieces of information. And so what we do is we rely on our biases. We lean into our stereotypes, and we make very quick decisions based on what we know and what we understand. So we all have blind spots. I would love for everybody to, this is where that whole thing of either doing the QR code. When I was playing with this, you have to send a message to 22333 with Megan Lytle 100 to open up the poll. But I want you to take a look at this individual and just start typing in the characteristics you see. What are your assumptions about this lovely person? What assumptions do you have about identity? Love it. So I'm seeing comments about skin color, that this individual is an athlete, comments about sexual orientation, that this is an Olympian. So I am going to skip ahead to the next. And this one, I'm going to play an audio. And I just want you to kind of, again, what pronouns, what gender, what images, what automatic thoughts come up from you when you hear this audio.
You know, I'm no stranger to hard times. So, see, you cried, you made me cry. You're going to be faced with adversities throughout your life. This was a pretty big one, but I just kind of relied on my hard work, getting through it. I know this sounds so small, but you know, dying in practice, you know, and just hard workouts. You find a way to just grind it out. Just put your head down and just keep going. Just keep moving forward. You know, you can never stand still. And that was my thing. Just never be still. Never get too focused on the now and just, you know, looking forward to, you know, what's to come. Yes, I was aware. There was a little bit of a delay. Yeah, just keep pushing. We'll see.
So we have assumptions again about gender identity, assumptions about race, ethnicity, region where this individual potentially lives. Clearly, some of you know who you're looking at and who you're seeing, because I'm seeing a lot of aspects about this individual's identity. Awesome.
Because we're not going to.
So these two things were the same person. The image that you saw and the sound that you heard were the same exact person. So for those of you who don't know what she looks like, this is Brittany Griner, Olympian, WNBA player. She was held in Russia for I don't even know how long as a prisoner. This is her voice. Taller people sometimes have deeper voices. It's nothing about her gender. I know nothing else about her, but her voice tells me nothing. And so those are one of those blind spots that we don't know based on how somebody looks or how somebody sounds. We'll do one more of these, so bear with me. Again, here's another image. I want you to just take a moment and describe your automatic observations, automatic thoughts. What are your thoughts about this person's gender? Just looking at characteristics, there's hairstyle, bone structure, features. It looks like this person has a little makeup on because every model and everybody on TV has a little bit of makeup on.
Awesome. So clearly we don't know anything about this person's gender. We didn't ask this individual. There are some individuals who see somebody that's feminine. There's some individuals that see somebody that is a male. And again, these are our blind spots. We see, what I'm seeing is I see high cheekbones. I see makeup that is accentuating the cheekbones. I see a smoker. So for those of you that are nurses, like there's worries, like do we need to start some smoking cessation with this person? There's probably some hair gel. So again, we're making lots of assumptions about who this individual is. All of these images are the same individual. So this is Rain Dove, a gender fluid model. They use they, them pronouns. Sometimes they dress super masculine, sometimes they dress feminine, sometimes super androgynous. And again, I think part of this is just to get used to taking a step back and take a moment with the assumptions, instead of just jumping right in and assuming that we know someone's gender or how to grade them. And it's tricky because it's so built into us. We're like, my kids, I'm trying to teach them how to be polite. And so sometimes we're trying to teach a little 5-year-old Miss or Mister and different things. And even in the car, there's some days where someone might cut me off and I'll be like, oh, why did they do that? And my kid was like, why didn't you say she or he? And I was like, I don't know that person. And then I made the mistake of calling one of my kiddo's classmates he, and my kid was like, they haven't come to class yet, Mom, you're not using the right pronoun. And I was like, I am doing something right. I just want you to take a moment to think about trans and gender diverse individuals you care about. Take a moment to think about your loved ones and your friends. And how do you think you'd respond if one of your loved ones comes out to you as trans or gender diverse? Or questioning their gender and not quite sure how they identify? And just pay attention to what blind spots you might need to hone in a little bit. And I encourage you, whether it's interacting with your colleagues, your friends, your patients, these are all things that I'm encouraging you to think about. Because honestly, talking with my WPATH mentor, WPATH is the World Professional Association of Trans Health. And we always talk about like working with trans and gender diverse individuals or folks that are close enough. Like if you're close enough to care about trans and gender diverse folks, then you're in the right field to do this work. That it makes such a big difference when there's people that you care about, because you're more likely to stand up and be an ally. When we talk about trans and gender diverse individuals, we so often pathologize. We're so often talking about the suicide rate, and I'm gonna be that person too, but I'm gonna put it in a different context. If we look at the general population, about 4% attempt suicide within the age of like 15 to 54 or so. Same age range, it's about 10 to 20 lesbian, gay, bisexual individuals. Probably pansexuals and other sexual orientations in that mix, but we don't ask those questions in research. And then we talk about trans and gender diverse individuals, that number jumps up to 39 to 55%. In the focus group that I did, when I asked how many folks had attempted suicide, everybody raised their hand, and it wasn't, did I attempt suicide? It's how many times do I attempt suicide? And in my focus group, it was 9 individuals who are trans and gender diverse out of the 10 individuals. This is minority stress. Being trans doesn't increase your rate of attempting suicide. It's all of the discrimination and the bias and the things that impact you day after day that increases the risk. Just having family members who don't accept your identity increases your rate by 8 times as much. So youth with rejecting families are 8 times more likely to attempt suicide. The benefits of allyship are huge. There's not a ton of research out there, but the one study that looked at kids in high school, 56% less likely to attempt suicide when they had just one person using the right name. Those numbers increase the more folks who are using somebody's name, and that was out of teachers, parents, schools. So just having an adult in your school use your name decreases the risk of suicide. Imagine what it's like in the Department of Psychiatry. When people are coming to us, they're in crisis. They're not okay. How much harm are we doing if we're not taking a step to think about what's this person's name and pronouns, and they may not match up? And how huge it is if we just ask, how may I address you? It's more than hanging a flag to be an ally. I love a flag, I have it in my office, I'm a complete hypocrite. But I think it's what goes behind those symbols. So I am wearing my trans flag lanyard and I've got my pronouns and my allyship. But what this says to somebody, hopefully, is that there's some level of cultural humility, some level of willingness to listen, and hopefully that you're affirming. Fingers crossed. If my patients see you wearing a rainbow lanyard or have a rainbow flag in your office, they're gonna maybe sometimes open up more to you. There may be more trust that if you have these symbols, there's a willingness to listen. So I have pronoun badges and pronoun pins and stickers back there, please grab them. But take it with responsibility behind it. That these are symbols of openness. And if you're not open to it, don't take them. I don't think it's helpful when we have these rainbow flags up and then we are not putting it into action. It makes a difference. And it's tough because language is so built in and starts off when we're little. So I remember like in grade school, it was always he or she. And then I got to grad school and my mentor's like, aren't you a female? Shouldn't it be she or he? Put yourself first. And now why aren't we just doing they? And you know, just that shift in language that if we just use they, them pronouns more frequently, it's gender fluid. It's all gender. You're not going to offend somebody. And same thing, like we have the language there. We already use it. We ask about people's parents. We ask about their siblings. We don't necessarily have to gender them until the individual tells us how they identify those individuals. And then I'll try to get a little bit into this, but also like for those of you who are providers and therapists, making sure that your documentation aligns with how this person identifies. So get in the habit of introducing yourself with name and pronouns. So all of my presentations have she, her after my name. My Zoom has she, her after my name, even my email. The more places I can put it, it's just, we all have pronouns. We use pronouns all the time, but so many people don't even think about pronouns. So tomorrow I will be handing out cookies and pronoun badges. And I have to put up little signs behind the pronoun badges because some people just start wearing them, almost like it's swag, but it's not swag. And I'll be like, hey, love that you're grabbing a pronoun badge. What pronouns do you use? And some people look at me like I'm nuts. And thank goodness I'm handing out cookies because then I'll be like, okay, if I'm gonna say this is her cookie, his cookie, whose cookie is this? And then they'll take a minute and look at what pronoun badge might make a little bit more sense. It's really helpful too, to just get in the habit of putting some context behind this. I think the biggest thing I see is folks are afraid to use their pronouns when they introduce themselves because they're worried about how other people are going to react. They're worried that if I introduce myself to an older patient, that the person's going to get upset with me and it's going to be uncomfortable. But if we put context behind it, that doesn't usually happen. So whenever I meet a new patient, I introduce myself with name and pronouns. And then I say, I'm going to ask you way too many questions about yourself. And I ask everybody these questions. And some of them are going to seem obvious, but I'd rather ask an obvious question than make an assumption. And we do this all the time. I remember, so I put in here cutie to like prompt my memory. My grandma passed, but I called her cutie because she's the cutest. And she would come to me and she's like, honey, why are they asking me about drugs at my appointment? Do I look like I use drugs? And I said, cutie, no, but you have a good doctor because some people do use drugs. And we have to ask these questions of everybody. We should ask all patients about their sex and their substance use and their gender and their race, ethnicity, instead of making an assumptions to treat somebody more holistically. And then I ask people, how may I address you? And what I love about this, a lot of the things we're talking about today doesn't just apply to trans people, because I've met some providers and they literally have like a trans day a week. So like they will have their regular practice and see all of their trans patients on Wednesdays, as if you need a different mindset to see trans and gender diverse folks. It's really just person-centered. That if we get in the habit of asking, how may I address you? That person where the title is really important because they're discriminated, then we know to call Mr. Smith, Mr. Smith. Then we know how to pronounce somebody's name. So these are things that are very inclusive across cultures and not just applicable to trans and gender diverse folks. It's also helpful too to default to gender neutral or all gender pronouns with your colleagues and your friends and trainees, because we don't know until we ask. I have a lot of colleagues that use they, them pronouns. And in clinical notes, I see them referred to as Mr. or Miss, and we don't need to gender another professional in our clinical notes of a patient. We can just say the nurse practitioner, or they met with this provider. We don't need to disrespect our colleagues by misgendering our colleagues in our patients' notes. And our patients usually kind of understand from the pronoun badges who we're misgendering, and then that's gonna impact your relationship with your patients. So I'm gonna challenge you all to speak up. If you hear somebody misgendering, whether it's a colleague, a friend, a patient, speak up and say something. And the most important thing is finding a way that's comfortable to do so, because when I was starting to be an ally, I wasn't good at it. And I would just be like, oh, I hate that word. People would say things that didn't sit well with me. And I realized that's not gonna be well received. But if I gently jump into the conversation, oh, you mean they, them. They use they, them pronouns. Or I can just type it in Zoom, a private message. I don't have to call somebody out because we have so many meetings by Zoom. Or I can interject and then use the correct pronouns. And sometimes I hold off a little bit and see if the person corrects themselves. And if they don't, then I jump in. So I encourage you to find a way that works for you and practice. If you're not good at cutting people off, practice in your car. It's fantastic. Cut off that musician and kind of get used to saying those things. Because I think it's really important for allies to speak up. I think the best thing we can do is if we see somebody else being misgendered, to have one of us speak up who is cisgender. And it also leads to mistakes. Again, we're all human, we all make mistakes. The one time I remember misgendering a patient in session was right after a treatment team meeting, where a nurse practitioner and the group therapist were using the wrong pronouns with this individual. And then in session later that day, we were talking about medication, and we were talking about asking the nurse practitioner a question. And I think in that context, it cued my brain to use the wrong pronouns. So when we use the wrong pronouns in treatment team meetings or in patient rooms, it's gonna increase the likelihood that somebody else is gonna misgender that individual as well. Oh, and the spoons. I like to talk about not having any spoons left when I'm exhausted, when I've had a rough day. I think it's also important too, because we shouldn't put the onus on somebody to speak up for themselves, because we don't know how many times they've been misgendered. We don't know how many times they've been disrespected. And again, I'm not gonna expect somebody to have the spoons to speak up for themselves. Same thing with patients. Again, most patients don't wanna be at a medical center. They don't wanna be at the hospital. Something is happening in their life where they need our support, and we're helpers. And so they may not feel comfortable speaking up and saying something because they're already at a vulnerable point. And I think that's something I challenge a lot of times too, is like, well, why didn't they just tell me their pronouns? And it just may not feel safe, because it's not really a safe place for trans and gender diverse folks right now. So getting pronouns right means I see you, that I accept you. And there's different ways to do better with getting the pronouns right. Part of it's just thinking about what works the best for you. I apologize if I jump around, because there's bits and pieces of the next few slides that all kind of like jumble in my head together. But there's things we can do to practice. Again, I'm gonna pick on myself because it's humorous, and then it's just a good example. I was gifted guinea pigs, not by choice. I was told I was given 2 female guinea pigs, so I don't have to worry about multiplying guinea pigs. I was okay with this. 4 months later, Hershey had Hershey Kiss. You are not gonna tell my 5-year-old that Buttercup is a boy. Buttercup is a girl. I don't know the gender of Buttercup. To me, Buttercup had the capability to make Hershey pregnant. But in our family, Buttercup has she, her pronouns. And so we can change the pronouns of our animals as a safe way to practice. Also, if you don't like, furry pets is hard. Like my dog, his name's Thurston, but I call him Mr. Thurston. He's kind of like a child to me, so having newer guinea pigs, it's easier to switch the pronouns with. But a goldfish, I don't have a strong bond with any of my fish. Goldfish are a great way to practice they, them pronouns. Or our cars. Some of us love to name our cars. I know there's like a tendency to name cars female names, but again, if you have a female named car, switch it up. It's just different ways to get used to it. And then finding different strategies. So when I'm in a meeting with new folks, I also like to just take a moment and be like, hey, can we introduce ourselves with name and pronouns? I don't know everybody in the space. And so the more that we're doing that, we're just getting in the habit of doing it. Getting it right can also out somebody. And that's the tricky part. Again, this is where it's really important. I don't know everything, you don't know everything, and we're gonna make mistakes. And there's situations that are really tricky. Sometimes people aren't out to us because it's not safe. And so I have to be mindful that if I'm working with a 14-year-old who is out to me and not out to their parents, if I use the right name in session, I might be outing that kid to their parents. And that could be dangerous. And so it's just important to be mindful of when we're using pronouns. Sometimes when I talk with my patients about using pronouns, can I use this everywhere? So when I call you, is it okay for me to use this name, these pronouns? Or do I have to be aware of family or roommates? Just to be mindful of. It's also really annoying and confusing when people call you the wrong pronouns. And if I think about like the 2025 shenanigans where like they're gonna just narrow it down to 2 genders, just take a minute. Just pretend I am president and I am deciding we are all men. You are no longer allowed to have any gender identity besides male. Doesn't feel so good. I don't want to be a guy. It's not how I identify. And so there's lots of things that are like really confusing about it. Like, what is it about me that looks like a guy? It's very frustrating and scary. And I've literally had patients like struggling, like, what is it about me that looks masculine or feminine? Because I keep getting misgendered and it makes no sense. And so people feel unrecognized and invisible. It's unsafe, and especially nowadays, there is safety in when people cannot figure out if you're trans or not. Because that's really scary nowadays. We literally have people moving across the country to Rochester because they're not allowed to be themselves in their state anymore. So we have medical refugees. Imagine the impact of our clinical notes. So again, for those of you that are in e-records, patients are reading their notes. We can see. And again, how does that feel? I just met with you for an hour and I spilled my guts out and you didn't get my pronouns right. I've had patients not go back to a provider because one thing in their note was wrong. But again, it's that piece of like, what is it about me that you don't see? What is it about those automatic? And some of our dot phrases are not great, but we're working on those. So I will kind of go through some of those in a little bit. But it's really huge when we use somebody's correct identity in their medical records that they can see. Even the language, like the number of times like allegedly the patient did this, or this person's aggressive. These are loaded terms that are frequently used in our notes, and it's gonna change how the next provider treats that individual. So regardless, again, trans or gender diverse, it doesn't matter. Just be more mindful of, do I want somebody saying that I allegedly did something about my medical care? It's not gonna sit well with me. So again, getting back to the person-centered approach. There's some spaces we automatically do this. For those of you that know me, I spent 3 months in the NICU. And so before Soji had gotten to this point, when babies are born and go to the NICU, the legal name in our medical record is baby, and I put in parent's last name. And again, this is where we have those automatic thoughts. I'm a mom, so when I was writing this slide, I originally put mother's last name, and then I remembered, no, trans guys have babies too. So whoever is giving birth to the child, it is that individual's last name and baby that the baby is named. I never once had to ask a resident or doctor or nurse to call my kids Morgan and Zoe. They just walked in and they just did it. We have tons of international colleagues that use another name. And the difference is these are convenient for us. It doesn't feel good to call somebody person or baby. We're dehumanizing. It doesn't feel good to mispronounce someone's name. So there's plenty of instances where we use another name for individuals and we don't second guess it. Why do we second guess it for trans folks when it can literally save their lives? Same thing with last names. I'm married. My legal last name is Lytle Flint. I started publishing as Lytle, so professionally I go by Lytle just so like all my CV matches. It's just how I function. But I actually had to tell people like, no, I don't go by Lytle Flint at work. And again, like we naturally just accommodate and shift our thinking when it makes sense, when we're used to doing this for some groups of people. And I'm going to challenge you, why are we limiting it? Why are we putting rules on how we're going to do this to help somebody? And we automatically already use all gender pronouns. Hey, they left their keys, or somebody left their shirt. We automatically do this. It's part of our language. Using they, them pronouns for an individual is not grammatically incorrect. As much as my second grade teacher would try to like slam it into my head, it's not. It is very grammatically correct. And then we write just like we would for anything else. It's not they is. When we're talking about a patient is they are. So all of those grammar rules still apply when we're using they as all gender. So for those of you that are in e-records, what can we do? We can bond with the electronic record system. When I do the sexual orientation, gender identity, or the SOGI form, I talk about it with somebody. I never fill it out unless they're in the room or on Zoom with me. And then I say, are you comfortable with other providers knowing your sexual orientation and your gender identity? Or are you worried about discrimination? Out of this limited resource of choices I can offer you, do any of these make sense for you? And then I kind of acknowledge the limitations of when we're putting people in boxes, these boxes don't usually make sense. I also let them know, just because I update this, I cannot guarantee every provider will do this. Some of it is our third-party systems. For blood transfusions, we need legal name. When somebody goes to labs for blood draws, it's the legal name. They don't have the capability to put the person's chosen name. So there's places where people are going to be misgendered, and I'd rather give somebody a heads up than change this and have them think everybody's going to use this. Some of our notes are not updated yet. You can right-click and edit to make it more affirming. If you can't right-click and edit, sometimes just starting your note. Hey, this person uses this name, this is their pronouns, it doesn't match with their SOGI form. I do this a lot of times for patients who don't want their SOGI form updated, but it's important that I get it right. Our wristbands too are improved, but that's at strong. I can't speak for wristbands across all of our medical systems. So small things of just, if we're printing out something and we know it's not the name somebody uses, cross it off and write their name. I can't change the system, but I can show you that I see you, and that makes all the difference sometimes. And then we're working on dot phrases. So it used to be dot pref name was the only way to pull in somebody from the preferred name category. Now, if you do dot f name, dot name, they are all pulling in the chosen name that individuals use. Only dot legal name will pull in somebody's legal name. And when we update the medical record, the chosen name is larger. I'm specifically using the language chosen name. In e-records, preferred name is hardwired into it. I have tried for 11 years to fix that. It's not my system, I didn't create it. But that's not the name that we should be calling that category. Somebody's name is not a preference. It's not like somebody's just gonna pick a different name for me. And it also makes it seem like it's an option if we call it preferred name. So the chosen name, once that is put into the system, is larger. A lot of nurses and folks in inpatient settings don't necessarily know where to find it on the wristband. After the legal name, in all caps, that's the name we should be using. Whether it makes sense or not. You know, I think it's what Gwyneth Paltrow's kid is Apple. Like, just because you don't register something as a name doesn't mean it's not a person's name. And so some of my patients have very lovely and creative names. And so some folks are like, I don't know if that's disrespectful to put that in and call them that name. But that's how they identify. That's the name that they use. It's not for us to judge or make an assumption about. For those of you that work in Access Center or other spaces where we're entering in the information, a lot of times we have to start off by asking someone's name. I had a patient who was misgendered because the person didn't listen to the name. It started with a k, and a male name was used instead of a female name, asking, is this your name? It doesn't feel good. Instead of making an assumption when we don't hear the name, you can repeat yourself. I didn't hear you. I must have a bad connection. Can you tell me your name again? We can also search for patients using their phone number, their date of birth. So if you have no idea what they said, we can gather additional information to find it if you need the visual cue. Because for some reason, when my kids spell a name, I don't process how to sound it out. I have to write it out in front of me. It's just how my mind functions. So part of it's just figuring out different ways to thoughtfully ask individuals what their name is so we can identify them correctly in the medical records. Sometimes at the front desk, folks will ask people for their legal name to sign in. We don't ever have to do that. If it's been updated, you can put in either name and the name will populate and we'll find that patient. It has quotation marks around it in e-records. That is not okay. So when you're writing notes, please don't put quotation marks around somebody's chosen name. Again, it makes it seem like an option. Megan is not an option, it's my name. And so a lot of times what I do is I'll write the name and then in parentheses, if I have to write legal name, I'll say legal name is this. And then the rest of the name, I use the name that they go by. When it comes to youth, I don't work with kids. I'm very grateful that I don't work with kids because I don't think I could deal with parents. If parents are affirming, all of the stuff we just talked about applies. If they're not affirming, they have access to the kiddo's chart until I think age 12, 13, it goes over to not having access. But that's assuming parents aren't forcing their kids to have access to the medical records. And then even with adults, if there's domestic violence or other things happening, other people may have access to the charts. I work with adults. I still have parents come in and change their phone number and do all sorts of weird things to my patients' charts until I tell them, change your password and don't tell your parents if it's safe to do that. But it's really important to know who has access and having that dialogue with the individual. So if I'm working with an 11-year-old and their parents are not okay with their name and pronouns, ask them, do you want me to use your legal name? Would you prefer for me to just use the patient and name and pronouns? A lot of times that's what nurses already do. It's already kind of like in our system. When you have like 500 notes to write in a day, the patient went to bed. It's smooth. We're not going to misgender somebody, but having that dialogue with an individual is really important. Again, practice. So we already talked about buttercup. We already talked about the fish. I ask my friends and coworkers for accountability all the time. You know, it's very safe in my treatment team to just speak up and be like, hey, I think we got the wrong pronoun here. Or, hey, we're really struggling with the right pronouns. What's going on with us today? But pay attention to how you learn. So I figured out a long time ago when I handwrite things, it just enters my brain in a different way. So when I do an intake with a patient, I handwrite out my first set of notes because it helps me gather the information I need, that important information about their identity, because that's really huge to me. Again, practicing in your car. If you have a hard time with something, sometimes it's just, you need that audio practice. Sometimes it's the visuals. You know, if you hear that voice on the phone and it doesn't match your automatic blind spots, put a Post-it note up. Put up a picture that matches that gender. There's different things we can do depending on how you learn to help. Yeah.
Oh, I'm sorry to interrupt. Just before we move out from teens.
Yeah.
I do work with trans and non-binary teens on a pretty consistent basis. And one additional dilemma we run into is because their identities are in flux.
Yeah.
They change their pronouns sometimes daily. And that makes note writing more complicated. And so the best solution we've come up with, maybe you've got a better one and maybe we could talk about it another time. But what we've been doing in the partial clinic is every sentence is just subject and then what happened. So patient said X, then patient said Y, then patient said Z. And it makes the note a little bit clunky. But what it does mean is that because there are no pronouns in it, it'll be coherent, you know, at the beginning of that patient's treatment encounter and at the end.
Yeah, absolutely. I think that's one way to do it. I think I'm hearing like research notes with subject instead of patient. Writing patient and subject doesn't always feel great as a clinician. Just use their first name if that's static, and it's not all, I hear you. But for some people it is. But again, just have a conversation with the individual. Like, it doesn't sound like you figured out like your identity. Like, there's so many different gender identities. I know you're not this, but we don't understand what this is. And so how do you want me to document this? Are you okay with me just saying the patient and using name and pronouns? Sometimes as a clinician, way easier than as a researcher if I'm doing things after the fact or transcribing. Sometimes I'll do notes in the session. And again, that's where like some of those mistakes happen. I have patients who are in the process of changing their name. They're not ready to update their SOGI. And so the camera has their legal name. For some folks, we refer to that as the dead name because it triggers so many thoughts of suicide. And it's hard to have that visual of the wrong name and then telling your brain to use a different name. But doing notes in session or in the moment can help with that and decrease the likelihood of misgendering the individual. My gentle challenge is like on the adult side, some folks were hired as one gender. And in their transition process, it doesn't feel safe to be their authentic selves. And so if they're coming to see me after work, the way they're gonna present may not match. And so again, part of it's that conversation and getting to know individuals. Is this somebody who has a fluid identity that we're figuring it out? Is this somebody who my blind spots may be challenged because the way they show up doesn't align with what I assume to be masculine or feminine or androgynous? But at the end of the day, really, transparency and having those conversations is the best thing we can do. It's that cultural humility, that openness and awareness. So small things make a big difference. Always, people ask me, how do I apologize when I make a mistake? Because we're gonna. So if you misgender somebody, apologize without defending it, without putting an excuse, and move on. And do better next time. The more that we put a defense and an excuse, we're then drawing attention to it. So if there's other people present, they're gonna tune into that conversation. And we're putting attention on it to the point where sometimes individuals feel like they have to take care of us. So I just harmed you and my apology is so big that they feel like they have to take care of me, except I'm the one that caused harm. And so be very thoughtful about the apology. And it's tough too, because I think it's easy, like when somebody's challenging us, when we're trying to be a good ally, when we want to be anti-racist, and then somebody's talking about things. You know, I've had some patients be like, oh, white women. And I'm like, yeah, I know. Like, you know, and at first, the first time I heard it, it was just like, I wanted to say something. And then I bit my tongue and I wrote it out. And then I realized, like, wait a second, I'm safe. This person feels free to share this with me because I'm safe. If I defend myself, I become that white woman that we're like annoyed with. So I think part of it too is just being aware of what does it mean when we're defending ourselves, when we're unnecessarily defending aspects of society that aren't going to sit well with the individual. Small things make a really big difference. Our system isn't the best, you know? And so if you already experience a lot of discrimination, when the system is flawed, it feels like you're being discriminated against, you know? And so to put this in context, when we order imaging like CT scans and whatnot, there's lots of incidental findings. And then because of that CARES Act, we get those incidental findings usually before somebody has a chance to call us. And our system isn't set up for people to call us with the incidental findings. So as a white cis woman, when those incidental findings came up for me, I called my doctor like, hey, am I supposed to go to you or the specialist? Like, who's going to talk me through what I just read? Because I don't understand. But for trans folks that already feel discriminated against, when that incidental finding shows up in their chart and nobody calls them, it means you don't care about me. See, I knew it. I knew there was something about me and you don't care about me. And it could impact that relationship. So those small pieces of transparency can make all the difference. So when I work with folks, I try to prepare them. Like, hey, you're gonna have a consultation. Like, do you realize you're gonna have to take off your shirt? Are you comfortable with that? You can take your own hoodie instead of the creepy gown, I promise. Like, there's different things we can do to problem solve with individuals to give them more control and empower them. Also, just letting them know about length of wait lists. It's insane. For those specialists, there was one specialty, it was 2 years to get in. And that's just to get on the wait list because I don't think their calendar goes out that far. And again, it feels really uncomfortable to hear that, but that's our system. So when somebody starts talking and I can be like, hey, there's a really long wait list, and I proactively let them know, it doesn't feel like they're just getting bumped. They're prepared for it. It makes more sense. And some of our informed consent is just written really awful. Like if you go to plastic surgery or some places, the way it's written on the top of it is like for general public. So it feels like you're consenting for like images and your information to be shared with the general public. That is not actually what happens. But again, if I prepare somebody like, hey, you're gonna go and you're gonna meet with this person and they are delightful, and then you're gonna have the consent form and it's gonna feel icky. But again, I see you, we're gonna cross that out and just write my name on top. This is who's gonna see those images. It makes all the difference. So I wanna talk a little bit about my work. Jackie Beckerman has been hugely supportive and connected me to senior leadership, who connected me to the Health Equity Program Support Office and helped me secure funding to build GPS Health and Wellness. I don't love what the acronym stands for, but I love the imagery of it, that I'm helping people on their journey. We have a patient navigator. Our symbol is a compass rose in the affirming colors. So we have a general hub of mental health providers, primary care providers at Manhattan Square Family Medicine. We have an RN care manager, a patient navigator, and we work really well together. There is a surgical hub that is trying to pull in all of the surgical pieces together. And then we look at it as a hub and spoke practice. So today, trans and gender diverse folks, again, it's not surprising that there's health inequities, there's discrimination and a lack of access to care. And so we're creating this program to help individuals and have a supportive and compassionate environment and trying to identify proactively what are the barriers to care and how can we remove them. Did you not go to the appointment because the doctor was a jerk? Or did you not go to the appointment because you didn't have transportation or you didn't have food in your belly? What's going on here? There's lots of things that are going to stop somebody from going, you know, and it makes a big difference. So if we can find that out ahead of time, it's huge. Same thing with general surgery. We have all of these surgeons in different pockets and we're trying to coordinate efforts and bring them together. So then when patients are going for one surgery, we can help coordinate. So it's not, okay, it's a 2-year wait for this surgery. It's a 6 months wait for this surgery, a year wait for this surgery. If we know that, we can help create that journey that makes sense for them. And so this is a ridiculous looking diagram of what we're trying to create, but patients come to us and we connect them with our patient navigator to figure out what are your healthcare goals. And once the surgery arm is a little bit more built up, they will either land with the general health hub or the surgical hub. If they don't really need us, then we just link them to the folks, all of the specialists that a lot of folks are coming to. And then a huge part of it too is just looking at those social determinants of health. We send financial assistance applications to every single one of our patients. If they have a name change, we look at, all right, do you need legal support to do that and help connect them to pro bono lawyers? We're looking at housing. If you walk into the GPS office, there are shelves of clothing and shelves of food. And then our office also is connected to the UR food pantry, so we can send you away with groceries. It's huge. I literally had patients come in and be like, wow, your team is going to save my life. Because they walk in and they can be themselves and they're supported and we're just listening of what do you need and how can we help you? And it's just the small things that make a huge impact. So I want to be, I don't know what time it is, I'm not paying attention super well, but I want to make sure that we have time for questions.
Well, thank you, Megan. So would you mind, one of the questions that came in, they're asking for the location of where you'll be with the stickers and pens
Yes,
tomorrow?
absolutely. So the locations change a little bit. From 6:30 in the morning till 9:30, we will have a station in the main lobby. And then we also have another station by the Flom atrium. And then 11 to 2, we switch it up because nobody's really coming in through Flom anymore. And we move that location into the Cafe 601. So come grab free cookies, pronoun pins, badges, all the fun things.
And for those that are here today, they're able to partake in the back with some of your.
Yes, I brought pronoun badges, stickers, and pins, and Scott brought more pins because they run out really fast.
And no cookies back there, though.
She tried. Okay, so we do have a question here. It says the New York Times recently published an opinion piece about the CAS review from the NHS on gender affirming care. I'm curious to know your thoughts on that.
So with these kind of pieces, I will make a PDF because I don't want to put traffic to that site because I don't agree with it. There's additional pieces that will question significant aspects of the CAS report. So a pediatrician who specializes in working with individuals with disabilities and that kind of disabilities pathologizing lens kind of feels very present throughout the entire report. Interviewed a lot of providers across England to figure out, and pretty much they had a system to work with trans and gender diverse individuals that was very busy and couldn't keep up. And so there was very long wait lists. So the essence of the report of looking at the system makes sense. The way it's written does not make any sense. Where's the citations and where's the research to back up what is being said? And so even when you're looking at some of this, they're labeling gender affirming care as an ideology, which is very familiar with the language that's being used in the states that are taking away rights from our folks, compared to, I think, cautious or conservative individuals. To put it in context, those cautious and conservative individuals don't think trans people exist. And so you have a report that's, again, you have people across all spectrums providing feedback about this to somebody who doesn't really understand all of the ins and outs of the system. So I read it and I got very angry. I have lots of citations. The one piece that I did take away from it is when we are working with young folks and kind of going back to you, there is fluidity and part of it's a cohort effect. It wasn't safe to be yourself for years and years and years. It's still not really safe to be yourself. And everything's evolving. And so maybe you realize you're not female, but you don't know if you're fluid. You don't know if you're masculine. You don't know if you're androgynous. And that feels like a really big choice to put on a child. And so I think the fear is that we're going to start doing hormones and puberty blockers and not fully understand what that's happening. But we already do this for people with precocious puberty. So it's not like we're making up something new and just doing it with trans kids. This is stuff that's been happening for years. It's not that trans hormones have been happening in the last 10 years. It's been happening for decades. We don't have enough research to back it up because the government won't let us. You know, if you look at the census data, it's not asking about gender identity. Trump shut that down. And so in the surveys that are population-based, actually asking folks about gender identity, it's very few and far between. So we are looking at data from Europe. Again, I don't live in Europe, so I don't know the quality of their data, but there's a lot of assumptions being made without looking at minority stress, without looking at all of the factors at play.
Can I ask a related question?
Yeah.
Sorry, over here, I realize
Absolutely.
you can't probably hear where I'm coming from with the speakers. So I think it's possible to criticize any particular review, and I think there are limitations to the CAS review too. But the National Health Service in Sweden and Finland also raised similar concern about the quality of the evidence. There was an article in the British Medical Journal in 2023 that said that there's a growing consensus that the evidence base for these treatments is pretty weak. And then Johns Hopkins published another one. And so it really does seem like there are citation-driven concerns that we're skating on thin evidentiary ice here. And much of the justification for using these treatments with limited evidence is that we're maybe saving lives, right? It's worth the risk. But we also don't have any evidence that those treatments do reduce suicide rates. You know, I'm a suicide specialist myself.
Me too.
And for like even much larger populations that are much better studied, we typically don't make claims like that. Can you talk about, as someone who sees these patients but who's not a specialist, can you help me understand how you navigate such murky evidentiary waters?
And to put in perspective too, I came here as a suicide prevention researcher. I did work with the Trevor Project. And this is literally all I've done for the last 10, 15 years is work with trans and gender diverse individuals for clinical and research. Again, like if we don't have the data, how do we say it's not this or that? We don't always have data to use prescriptions off label, and yet it happens all of the time. When you have cancer, you're very often signed up for a research study because we don't necessarily always have the data. It's a moving target. And again, if we look at, the problem is when we talk about trans folks, we're often looking at cis research. And so we're looking at research about folks who their sex identifies with their gender identity. We do the same thing for intersex kids. We do the same thing. So it's been happening for years. Why are we not saying anything about those groups? So in the laws that are shutting down everything for trans and gender diverse kids, sometimes you can still get hormones for intersex individuals. And so I think part of it is weighing out the pros and the cons for an individual. So in endocrinology, there was a movement to stop older folks on hormones because there were risks of blood clots, and they were worried about how estrogen is going to impact the body. But what about the informed decision-making of the patient? You know, and so for that kid who hasn't hit puberty yet, it makes a big difference if we can halt it. And a lot of times doctors are pretty damn conservative. So when folks are more fluid, a lot of times they might just start them on spironolactone and not start estrogen. And so there's a lot of doctors, again, who have been doing this for years, who probably there's years and years of data. And now if you publish that data, you put a target on your back. And so we're in this really sticky place of there's data to be looked at that can balance out some of these arguments. But if we do that data, we're going to have threats. You know, I run a trans health echo, and we already had threats against us. They did a FOIA request for one of our participants and did a write-up about us, and pretty much saying that we were like recruiting trans kids from schools to enforce our ideology on folks, when really the whole point of the trans echo is to teach providers across the region how to work with trans and gender diverse adults. We're not even focused on youth. And so there's lots of arguments you can make either way. At the end of the day, do we have the best data? No, but we have clinical experience, decades and decades of clinical experience, and risk reduction. And so I think we're in a space where we have to make decisions that don't always feel comfortable, but I think most providers are doing things thoughtfully and cautiously. If somebody doesn't have a supportive family, my guess is those providers are going to be a little bit more cautious before they start them on hormones. In general, we're not doing surgeries on trans and gender diverse folks. You know, even here, one of our providers had a highly edited clip of them on the Tucker Carlson show, essentially suggesting that we do genital mutilation and castration, chemical castration, I think was the language. We don't. We have a gender health service that cautiously prescribes hormones to families that are supportive. And again, there's lots of conversations about puberty blockers, making sure that somebody is aware. It's an informed consent process. So there are those conversations. This is what it could do to your fertility. This is what to expect. And there's a lot of decision-making involved. I mean, we give little kids birth control all the time. Children have babies. Like, there's lots of things that feel uncomfortable with healthcare. I worry more about taking rights away from people when we don't really know who those people are.
Thank you, Megan.
Yeah.
With the last minute that we have, would you mind just providing some information about the Pride Parade this weekend?
Yeah, I will do my best. Some of the folks that are running it are supposed to update the website this afternoon. I sent out a message. So my understanding is that 9:30 to 10:30 is where U of R will start to line up at Science Parkway area. There will be signs within Science Parkway, and look for people in blue shirts to help get you to the designated spaces. And then the march will go into the Highland Park. U of R always has shuttles. There is information online, but I can pass it along to you. And if Amanda can put it out to DICE, we can do that as well, just to make sure the information's spread. But I just looked it up this morning and can't really speak very clearly about it.
Okay, well, thank you.
Yeah.
Please join me in thanking Megan for all her helpful information. And if you have any questions, any follow-up questions for those that are here, feel free to chat with Megan. Those that will put a question in the box link or in the Q&A, we'll be sure to get those answered from Megan as well. Thank you.